I'm Esther from Singapore. Thank you to the organizers for the invitation to give this talk at the annual Diabetes and Ramadan International Alliance Conference. The topic I've been given is on Ramadan and monitoring. These are my disclosures. I'll be looking at the importance of monitoring during Ramadan, comparing the current glucose monitoring technology, a comparison between capillary blood glucose monitoring and continuous glucose monitoring, some guidelines on glucose monitoring during Ramadan fasting. We will also be looking at telemedicine and telehealth for monitoring, and then some concluding remarks. Ramadan fasting is a highly anticipated event in the annual calendar for our Muslim patients. Now, fasting during Ramadan for people with diabetes carries considerable challenges. And this really depends on their risk stratification. In the latest Diabetes and Ramadan Practical Guidelines in 2021, the risk stratification divides our patients into low, moderate, or high-risk groups. And the risk of metabolic complications such as hypoglycemia, hyperglycemia, diabetic ketoacidosis, and dehydration is particularly important. The graph on the right here shows you the CGM tracing of patients with diabetes who fast during Ramadan. From these CGM studies, we've come to understand in greater detail our glucose profiles during fasting. You can see that the risk of hypoglycemia is particularly increased during the last 3 to 4 hours of the fasting period, and the glycemic variability becomes a lot higher during the fasting period. At the same time, after the breaking of fast or iftar, the blood glucose levels may rise and may stay sustained for a period of time. And this is due to the types of food that may be consumed during the breaking of fast. In order to mitigate the metabolic complications and dehydration, it is therefore important to provide pre-Ramadan focused diabetes education. Monitoring is also an important aspect in order to mitigate the risk of hypoglycemia, hyperglycemia, and DKA. Monitoring includes blood glucose monitoring, as well as perhaps an increase in healthcare provider visits. In the post-Ramadan period, it's important to review and learn from experience and counseling for future Ramadan fasting periods. Now, this is the Diabetes and Ramadan Practical Guidelines in 2021. You can see that our patients can be divided into low risk, moderate risk, or high risk. And the most important part is really the monitoring of the patient. So based on the risk stratification, the frequency of self-monitoring of blood glucose then can be individualized. All individuals should also break their fast if their blood glucose is in the hypoglycemia range, less than 3.9 millimoles per liter, and to recheck within 1 hour if the blood glucose is near the hypoglycemia range, between 3.9 to 5 millimoles per liter. If the blood glucose levels are high, more than 16.6 millimoles per liter, or if they already have symptoms of hypoglycemia or acute illness occurs. Let's have a brief look on the methods of glucose monitoring, the advantages and the limitations that each method confers. So capillary blood glucose, or CBG, the advantage is that physicians, healthcare providers are all very familiar with this method of glucose monitoring. It is quite accurate and of relatively lower cost. The limitation really is the inconvenience and the pain on finger pricking. It provides time in point measurements and is sporadic. And because it has to be done in a public place, or it can be deemed to be antisocial, because patients will need to have their blood glucose meter, test strips, and lancets with them and have to finger prick. On the other hand, continuous glucose monitoring can be divided into real-time continuous glucose monitors or intermittently scanned continuous glucose monitors, or more frequently known as flash glucose monitoring. The advantage of CGM is that it provides real-time and full glucose profiles. It's able to provide alerts and alarms for hypos and hypers, and enables data sharing with the caregiver and healthcare provider. The limitation really is the cost. Some of these CGMs also require calibration with a finger prick blood glucose and the lag time, which we will see in greater detail in the next few slides. In flash glucose monitoring, it also provides the advantage of full glucose profiles via intermittent scanning, no calibration required, and also has that benefit of data sharing with the healthcare provider. The limitation is that in the first generation of the flash glucose monitors, there are no alerts or alarms. However, it's present in Libre 2, which is not available in our region. It is also can be considered costly, and there is still that limitation of the lag time. So let's first look at capillary blood glucose monitoring during Ramadan fasting. It's important that as healthcare providers, we clarify the misconception that blood glucose testing invalidates Ramadan fasting. In addition, we mentioned that the frequency of blood glucose testing needs to be individualized, and this depends on the risk stratification profile of our patients into low, moderate, or high risk. This is dependent on the type of diabetes, the medication that the patient is on, whether they are high risk for hypoglycemia agents, such as sulfonylureas or meglitinides, or insulin secretagogues, or insulin itself. The risk for hypoglycemia also needs to be assessed, and the risk for hypoglycemia can be assessed by knowing the frequency of hypoglycemia that this patient has, whether the patient has impaired awareness of hypoglycemia or any prior history of severe hypoglycemia. In terms of impaired awareness of hypoglycemia, it's important to use one of the scores that you may be familiar with, such as the GOLD score. Now, the GOLD score is a visual analog scale between 1 to 7. And the question that we ask the patient is that, are you aware when your hypos are commencing? 1 means that they are always aware, and 7 means that they're never aware. And a score of 4 or higher indicates impaired awareness of hypoglycemia. Nowadays, a lot of the blood glucose meters are what we call connected blood glucose meters to smartphone or web-based applications. And this also allows data sharing with the healthcare provider and remote monitoring. And this facilitates telehealth. The picture on the right here shows a connected blood glucose meter that we use across the restructured hospitals in Singapore, which connects to the smartphone application called the My Sugar app. And here, patients are able to Bluetooth connect their blood glucose meter with their phone and then export the data to the healthcare provider. They can also input meals, and it gives the patient quite a comprehensive view of their data. So in patients with type 1 diabetes, and I would say type 2 diabetes on intensive insulin therapy or premixed insulins, now frequent glucose testing is fundamental to ensure safe fasting. The Diabetes in Ramadan Practical Guidelines 2021 says that the use of CGM or FGM is superior to SMBG monitoring and should be the method of choice if feasible. And of course, fasting should be broken immediately with hypoglycemia, where blood glucose is 3.9 millimoles per liter and below. The picture on the right shows the 7-point guide for self-monitoring of blood glucose during Ramadan. When to test? Now, the number of blood glucose monitoring needs to be individualized, as we mentioned, based on risk stratification. And the first test can be done during the pre-dawn meal or sahur, the second in the morning, third in the midday, fourth in the mid-afternoon, fifth in the pre-sunset meal or iftar, sixth in the 2 hours after iftar, and at any time when there are symptoms of hypo or hyperglycemia or feelings of being unwell. Now let's look at current CGM technology. As you may know, CGM measures the glucose levels in the interstitial fluid continuously and updates the glucose level display every 5 to 15 minutes. It can be continuous or it can be intermittently scanned. For the CGM, there are 3 components: the sensor, the transmitter, and a monitor to display the information. It provides real-time as well as retrospective information to detect hypo and hyperglycemic excursions with alerts and alarms for real-time CGM. The trend arrows are particularly useful because they can help our patients in predicting impending hypoglycemia or hyperglycemia in real time. And our patients can then take measures to reduce the risk of hypoglycemia or even avoid hypoglycemia. Our patients and healthcare providers can also view the glycemic variability from the downloads. And using all this glucose data, it helps them to make adjustments to therapy, whether it's insulin or others. And in sensor-augmented and closed-loop insulin pumps, it is particularly important as it informs the insulin pump on how to adjust the insulin delivery. We mentioned some limitations of current CGM technology, and here I would like to just go briefly through. Firstly is the accuracy. Now, this is often reflected by the mean absolute relative difference on MARD. The lower the MARD, the more accurate the device is, and the lag time. Now, the lag time is shown on the right-hand side. If you can see the picture here, this is particularly important when blood glucose levels are changing rapidly. Then the sensor lag time becomes more obvious. For instance, in figure 1, it's showing when glucose is rapidly changing. So the blood glucose is showing 8.5, but the sensor glucose may only be at 7 millimoles per liter. And this is because of that lag time. After insulin therapy, which is figure 2, the blood glucose will have fallen already, but the sensor glucose may be lagging behind. Similarly, after food in picture 3 and after exercise. So this figure 4 actually shows that the blood glucose is already in the hypoglycemia range, but the patient may find that the sensor glucose is not showing a hypoglycemia range as yet. So it's very important that we manage expectations for our patients, as well as teach them to perform a confirmatory finger prick testing when their symptoms do not match the sensor glucose reading. There can also be interference from certain medications and other factors. And known medications which are commonly used, which can interfere with accuracy, include that of ascorbic acid, acetaminophen, lisinopril, and others. There are also other factors which may impact on accuracy. There can also be loss of function of the sensor, which limits the lifetime of the sensor. And patients may find that the accuracy of the sensor becomes less during the final days of sensor life. Certain CGM devices also need calibration for certain sensors, and this results in inconvenience or discomfort with finger stick capillary blood glucose. At the same time, cost is a major limitation, particularly in our region where there is lack of reimbursement. So the use of CGM during Ramadan, what has the available literature taught us? Well, it has really given us a greater understanding and appreciation of the glucose patterns that are observed during Ramadan fasting. This was an important study by Lisan et al., which showed that the CGM curves showed a gentle dip in the last few hours of the fasting period, followed by a rapid rise in the interstitial glucose right after iftar. This other paper, also by the same group, showed that the pre-Ramadan period, you can see is represented by the line in red, showed generally better glycemic control. The Ramadan period is reflected in green, where there is an increase in hyperglycemia risk, especially after the iftar timing. And the mean glucose and time spent in hyperglycemia is higher in the post-iftar period. There is also a small risk of hypoglycemia in insulin-treated groups, and the glycemic variability increases during the Ramadan period. And the post-Ramadan period, the glycemic control remains higher compared to the pre-Ramadan period, and this could be postulated to be due to the feasting that occurs post-Ramadan. Similarly, in adolescents, the findings were somewhat similar, that there was wider blood glucose fluctuation during fasting and eating hours, and even unreported hypoglycemia. But the use of CGM combined with good patient care results in improved glycemic outcomes during the Ramadan period. So this is a study performed by Professor Mohammad Hassaneh, which showed that patients who were high risk, were in the category of the high risk diabetes who insisted on fasting. Well, these patients were put on a continuous glucose monitoring device, a flash glucose monitor, and then had several of their parameters being measured and monitored. And they were able to show an improvement in glycemic control after Ramadan, as well as an increase in the time in target. And although there was a slightly greater mean number of hypo events during Ramadan, you can see that the hypoglycemia period was greatest in the last few hours of the fasting period. How about telehealth monitoring during Ramadan? Well, the role of the COVID-19 pandemic has increased the use of telemedicine and telehealth platforms. And telehealth is particularly useful when physical contact is limited. And the possible roles of telehealth monitoring during Ramadan include, firstly, during the pre-Ramadan period, whether it's a one-to-one or group education, which can be delivered via teleconsult, monitoring blood glucose using connected blood glucose meters and data management platforms, whether it's from CGM or insulin pump data management platforms, teleconsults to monitor well-being and any queries or advice during Ramadan fasting for medication adjustment, hypoglycemia or sick day advice, and post-Ramadan advice and education. These are just some papers to look at the impact and usefulness of telemonitoring during the Ramadan fasting period. And it showed that really the telemonitoring group had improved glycemic control and was a useful adjunct to reduce the risk of hypoglycemia during Ramadan with no deterioration in glycemic control. The paper on the right also concluded that virtual pre-Ramadan visits are an effective alternative to in-person visits when managing people with type 1 diabetes who plan to fast during Ramadan. So in conclusion, monitoring during Ramadan, well, during the pre-Ramadan period, it's important to assess the risk of fasting by doing the risk stratification and provide pre-Ramadan diabetes education. In fact, because Ramadan this year falls in March, I've already started to counsel my patients on Ramadan fasting. In this pre-Ramadan period, it's important to advise on the frequency and type of glucose monitoring, which should be individualized based on risk stratification, to assess the risk of hypo and hyperglycemic emergencies during fasting based on the pre-Ramadan glycemic variability or glucose control, and consider the use of telehealth through by delivering Ramadan-focused diabetes education through the use of telehealth. It's especially useful when physical contact is limited. During Ramadan, monitoring enables close and remote monitoring to avoid hyperglycemic emergencies through the use of data sharing platforms. And we saw that the CGM curves that the risk of hypoglycemia is highest in the 3 to 4 hours, in the last 3 to 4 hours of fasting, and with the highest glycemic variability after iftar. This can help to guide medication adjustment midway through and near the end of fasting. For CGM users, they should be advised to use the trend arrows in the CGM to avoid impending hypo or hyperglycemia. Alerts and alarms for hypos and hypos for real-time CGM to both the patient and caregiver or healthcare team, and the use of telehealth for remote monitoring and teleconsultation for advice on medication adjustment and sick days. In the post-Ramadan period, it's important to review what their experience during the fasting period was like, and that our patients learn from experience for future Ramadan fasting, and to, of course, provide feedback on to our patients on the foods and beverages to limit or avoid during the festive celebrations. Well, with that, I thank you very much.